So today I am joined by the wonderful Dr. Emer MacSweeney. Thank you very, very much for joining me from Recognition Health. And today we're going to be discussing about early detection of Alzheimer's, and unpacking maybe signs that people miss and new tests that are changing how diagnosis could look and what that could mean for the future of dementia care. So thank you so much for joining me today. I hope you are very well.
Yes, thank you very much. Thank you.
Good, good. So just to start, please would you introduce yourself to the listeners and tell them a little bit about your background and the work that you're doing at Recognition Health?
Of course, yeah. So I'm co-founder and CEO of Recognition Health, and Recognition Health consists of a number of brain and mind clinics. So we have a huge number of consultants, probably about 160 worldwide, working with us at our Recognition Health clinics, where we specialize in early, accurate diagnosis and access to the sort of like most recent and effective treatments for conditions of the brain and mind. And whilst we're going to focus on Alzheimer's today, just to say at Recognition Health, we cover really everything from age 0 to, 120. So we actually do neurodevelopmental, traumatic brain injury, as well as the neurodegenerative diseases. But obviously a huge part of what we do is with Alzheimer's disease, because Alzheimer's disease is effectively a pandemic. It's incredibly common. Mm-hmm. And there's been massive advances in neuroscience, in biomarker development, and in drug development for Alzheimer's disease over the last few years. So we work both within the clinical trials with all the most recent advances, as well as providing those treatments and biomarkers on the market now, as they're starting to emerge and really change the whole paradigm for diagnosis and treatment for Alzheimer's disease. Mm-hmm. By background, I'm also a neuroradiologist, but work very heavily myself in the Alzheimer's space.
What draws you particularly to that Alzheimer's space then? When you say you're working heavily in that area, why, what's your...
Well, several different things. Firstly, the advances in, as I said, treatments and diagnostics in the Alzheimer's space is almost sort of like phenomenal. It's exponential at the minute. Secondly, as anyone will know who either knows someone themselves or is suffering from Alzheimer's disease, it's an absolutely devastating condition. Mm-hmm. Thirdly, there are treatments and biomarkers now emerging on the market. So it's an area of medicine in which it really is possible, sort of like today for the first time, to really be able to make a significant difference. Mm-hmm. And it's absolutely essential that we do. I mean, I'm really sort of like honored and humbled to be in a position where I can actually sort of like hopefully make a difference to people and their families in terms of this whole sort of like new paradigm really for treatment of this condition.
Mm-hmm. And how many clinics are there in the UK?
So currently we have 4 clinics in the UK, in Birmingham, London, Bristol and Winchester, where we actually undertake clinical trials as well as provide these new treatments and biomarkers on the market. And then we also have 4 clinics in the US, in Washington, sort of DC area, in Houston, Dallas, Fort Worth, and in Chicago. Wow. So we're quite busy.
Yeah, it sounds like it. And the clinical trials, how do you reach out to people that have been diagnosed? I'm assuming that's how it works, but how do you do that?
So it's a number of different things, actually. And we've spent a lot of time trying to make it easy and possible for people to contact us. So we actually obviously work through the sort of like medical network, but to be honest, I would say about 95% of people who come to us have found us through sort of like just, like online, social media, marketing, advertising, and actually increasingly through word of mouth. So people say, look, I'm worried about my memory and all the related sort of symptoms, and they just sort of hear Recognition Health is the place to go. So more often than not, people contact us. But meanwhile, we are always out there sort of essentially really focused on education, because it's quite extraordinary. But the biggest problem with this condition is people not understanding how important it is to recognize symptoms and to recognize them early. It's exactly the same as treating cancer. You need to recognize symptoms as soon as possible. And as soon as you potentially recognize symptoms in yourself or in somebody else, you need to seek a diagnosis and treatment. So we do lots of educational events and I think conferences, in fact, where I met you.
Yeah.
And we're constantly, trying to put out, we have podcasts, I've done TED Talks, we have webinars, like everything. And there's massive information on our website as well. Both our US and UK websites are sort of interconnected to really try to provide people with as much information and knowledge as possible. And as in everything, knowledge is power. And you really need to, sort of be proactive. And the only people who are going to be most concerned about you as an individual, if you're worried, is yourself, your family, and then people like us whose job it is to provide diagnosis and treatment.
Yeah. And when we talk about those early symptoms then and noticing those, it's not just about memory, is it?
No.
So what other things should people be looking out for?
Yeah. So it's actually the biggest or easiest way to put it in one big bracket, so to speak, is it's really all aspects of your thinking ability. Now, obviously, there are lots of things that can affect our thinking ability. But as we grow older, if we find our thinking ability is changing and we're not as mentally sharp, in fact, the most common cause is the very early stages of Alzheimer's disease, because, as I said, it is incredibly common. But the sorts of specific things to look for are problems with short-term memory. So not long-term memory, that's usually fine. It's forgetting details of recent events and conversations. It's having to make lists. It's maybe when somebody calls you, you think, oh, I better write that down, otherwise I'll forget. Or providing reminders on your phone for yourself. However, it's not just short-term memory, and it doesn't always present in exactly the same way. Actually, one of the things that can be very common is people presenting with an inexplicable level of anxiety. They're sort of like anxious in a way that they know isn't sensible, and that about things that they wouldn't have been anxious about previously, maybe about going on a trip or something like that. But then it's also problems with language. So it's maybe using more generic words instead of specific words. So, for example, for the mouse for your computer, saying, oh, where's the thingy for my computer, as opposed to where's the mouse? It's also problems with calculation, which also, if you have this, you recognize it. It's really your facility with numbers just doesn't seem to be quite as sharp. It's problems with concentration, so like you're in the middle of doing something and then you sort of forget you haven't finished it and you go and do something else. Sometimes it can just be difficulty finding your way in a familiar environment. So it's sort of like you're going around a roundabout, you've driven around loads of times, and suddenly you don't know which exit to take. It's suddenly somewhere very familiar, doesn't look familiar. And it may be just for sort of like, half a minute, something like that. But what tends to happen is you then start to notice these things happening increasingly. And it's very rare for people to not be aware of this. Now, most people just try and hide it or cover it up, or they're in denial or whatever. But actually, I find now increasingly where we do actually have treatments through the trials or on the market, that so many people are contacting us with very, very mild symptoms. And then we do the special diagnostic biomarker tests and they're positive. So I think probably this is even more common than we had previously thought. But the biggest mistake, if you like, that people make is this myth that losing our memory is normal as we grow older. It isn't. It just isn't normal. Now, yes, you might forget one or two names, things like that. But generally speaking, losing our memory is not normal as we get older. I mean, it's a bit like, in the old days, if people thought, losing your eyesight as you get older is normal. It's not. Most people just had cataracts. Like now, we don't consider it normal to lose your eyesight as you get older or to start losing your hearing. I mean, there's a problem there. And the biggest obstacle to people seeking early treatment is people thinking, oh, it's normal and all my friends are the same. Yeah, all your friends are the same because it's really common.
Yeah, it goes back to that education again, though, doesn't it?
Yeah,
for sure.
It really, really does. And it's the same as, I don't know, like in the past, somebody having a lump in your breast or something, and saying, oh yeah, my friends have got that and that's absolutely fine, and saying, oh well, I'll just sort of wait and see if it gets bigger. You need to know, and you need to know immediately.
Yeah, and the sooner the better,
Well, the
right?
sooner the better, because there are lots of different causes for let's call them thinking ability problems. And it can be just something like thyroid disease or low B12, low folate, something like that. Or it could just be a sort of like I don't know, anxiety, depression, something completely disconnected. And you need to know, because if it is something that's reversible, you need to get treated and you need to get it reversed as
Yeah.
quickly as possible. But if it is something that is progressive, i.e. is the early stages of Alzheimer's disease, and there are other neuroprogressive or neurodegenerative diseases as well. It's just Alzheimer's is the most common. But if it is one of these conditions, you need to know so that you can seek treatment as soon as possible.
And I was ticking off when you were listing some of those symptoms. I'm like, oh, yeah, I do that. Yeah, I do that. But then I'm sort of thinking, but I'm putting myself in that perimenopausal bracket as well.
Yeah.
So apart from going round the roundabout several times, I could probably tick a lot of those boxes. But like you said, it could be something else.
Absolutely.
But it's better to be checked sooner.
Exactly right. I mean, without question, age is the biggest risk factor. But we are increasingly seeing younger people. Now, when I say younger people, obviously there is a form of Alzheimer's disease when people are very much younger, 20s, 30s, but that is very rare, and that's a sort of genetic thing. That's totally different. But I don't want to sort of like freak people out because that would be inappropriate. But we do see people in their sort of like 50s, certainly in their 60s, 70s, very common, and sort of like, obviously very common in the 80s. But I think the most important thing is that you can't tell by just looking at somebody, what's causing their problem. But we do have tests now that are so much more sophisticated that can give a clue as to what's going on. And as I said, the perimenopausal symptoms are very common, as actually are, after pregnancy, people often sort of think, oh my God, I can't remember anything.
Yeah.
And again, that's really normal as well. But certainly I have seen many people who have these symptoms, let's call it in the perimenopausal phase, and just dismiss it and assume that's what it is. But then sort of like later realize that was sort of like, the early symptoms. But it's not to freak everyone out by any means. It's really more for people to be proactive and to find out, is this something that can be treated, or is this the beginning of something that's progressive, but which today increasingly can also be treated.
What's changed over recent years to help with that early diagnosis then?
So the biggest thing is we now have what are called biomarkers.
Can you explain what that is? Well, I'll ask you to break things down just to...
No, sure. So going back a bit, originally the only way somebody, if you like, would surmise that someone was having problems with their thinking ability and that they might be experiencing the early stages of Alzheimer's disease was by doing a cognitive assessment. And actually people with, sort of like a huge amount of education and who just got really good brains, like a really good athlete or something, they actually were at quite a disadvantage because they could compensate for quite some time. But essentially, you didn't have any way really of knowing what was causing these cognitive symptoms. So by definition, people did not even sort of think about what it might be due to until symptoms had really progressed to a point, which today is almost like, beyond the point where these new medications work. So the biggest breakthrough, there's two big breakthroughs. There's two new medications, but alongside that are these diagnostic biomarkers which can detect evidence of the disease pathology while symptoms are very mild. And that's the only way you can confirm a diagnosis when symptoms are very mild. You cannot confirm a diagnosis by talking to somebody or doing a million billion tests. You're just not going to get it right. Now, when the disease is really advanced, you're going to get it right just statistically, but also you're probably going to get it right, because there's a sort of fairly typical pattern of cognitive decline. But the biomarkers come in several forms. So the sort of like earlier biomarkers were looking at spinal fluid. So that's doing a lumbar puncture, taking some spinal fluid, and looking at the key proteins, looking at amyloid protein and tau protein in the spinal fluid. Then the next thing that, and we still do that, the next thing that came along was something called a PET amyloid scan. So that's a scan where it's like a CT scan to a certain extent, but you give somebody an injection, just a little small injection in the arm, just a clear fluid. And in that little injection is a molecule which is attached to a tiny packet of radiation. And what happens? It whizzes up into the brain. And if there is abnormal amyloid protein in the brain, it will attach to it, give out a little pocket of radiation, and that's what we detect. So that's highly sensitive, highly specific for identifying the presence of abnormally accumulated toxic amyloid protein in the brain, which is the hallmark for Alzheimer's disease, particularly when present in association with mild cognitive symptoms. Now, the sort of revolutionary thing coming along are blood tests. Because it's a common disease, we need a ubiquitous, inexpensive diagnostic marker. So the new blood test, now this is not yet sort of like approved in the UK. We actually do have it, and we do it as part of a screening assessment at Recognition Health. But it's approved in the US, and there's loads of people having this test in the US now. And that's something called a p-tau217 blood test. And the important thing about the p-tau217 blood test is you can get 3 results essentially. If your result is high, it's an indicator that you have high amyloid protein in the brain, hallmark for Alzheimer's disease. If it's low, it means you don't have it. And if it's there's a small sort of like 20%, so to speak, indeterminate range. And if your result falls in the indeterminate range, then you need to have a PET amyloid scan to absolutely confirm whether or not that amyloid protein is high. And the whole way this correlates with Alzheimer's disease is Alzheimer's disease, like most diseases, is this basically just neuroinflammation. We don't really know exactly why it starts, but it sets off a train of neuroinflammatory reactions, if you like, or processes. And eventually what happens is it triggers a process called astrogliosis. And astrogliosis is essentially your astroglial cells start behaving abnormally. So these are cells, they're like your police cells. They normally control and patrol your brain for toxins and everything else. So they start behaving abnormally. And as a result, your normal amyloid protein starts to overproduce. And it overproduces to an extent that it exceeds the rate at which the brain clearance mechanism is clearing your amyloid. So you get this buildup of toxic amyloid protein. And when that toxic amyloid protein in the brain gets to a certain level, it triggers another process, and that's called microgliosis. So your microglial cells, which also sort of like clean up the brain all the time, they just don't function properly. And then what happens is when that starts to go awry, it triggers another protein to start behaving abnormally, and that protein is called tau. So you start to phosphorylate your tau, you get this p-tau, and the tau protein's inside the brain cells, and it spreads through the brain, sort of like, it's not a cancer obviously, but it sort of like spreads through the brain cells. And that is actually what correlates most closely with clinical symptoms and cognitive decline. So what we know is once you start to get cognitive symptoms, if you have high amyloid protein, which we can measure by the PET amyloid, the CSF, or by the p-tau217 test, then we know if symptoms are present, and this is the time at which you become eligible for treatment. What we know is that the microgliosis is already active and the tau protein has already started to spread in the brain. And the new treatments for Alzheimer's disease, and those treatments that are in trial, as well as the new treatments on the market, they are designed to sort of like slow down this neuroinflammatory pathway, and thereby ultimately to slow down the tau protein through the brain, and thereby slow down further progression of disease and symptoms. So there's nothing mysterious about this disease. I mean, it's just like any other disease. It's like,
Yeah.
your blood sugar or your blood pressure or your cholesterol. It's just like anything else that gets out of control and out of equilibrium. But the real problem with Alzheimer's disease and the amyloid and the tau protein is that when it destroys brain cells, because brain cells are so specialized, they can't regenerate. So you can regenerate your muscle cells or your skin cells or your liver cells, but you can't regenerate brain cells. And that's why this is a race against time, because you need to act before you've destroyed too many brain cells.
And that comparison there, as it, it's being like high blood pressure or diabetes, but we can sort of pinpoint like why we get diabetes, the health factors, the lifestyle factors for that and high blood pressure, but yet we don't know why on the Alzheimer's side yet.
So we know a lot, actually. I mean, what is really important is it's now it's above 40%. I think the last I saw it might be even up to about 49% of risk factors for Alzheimer's disease are what we call disease modifiable. So what that basically means is they're lifestyle risk factors that we can change to decrease risk of developing Alzheimer's or delay the time that one might develop Alzheimer's. Now, it's important to recognize that this is one of those things, like if the whole world did all these things, then the incidence or prevalence of Alzheimer's disease would pretty much halve. But as an individual, it is still really, really important. And they're not sort of esoteric risk factors. They're like all things we know.
Yeah.
So probably the biggest one is exercise. Exercise is phenomenally important in slowing down or decreasing sort of like risk of Alzheimer's disease. It's like so incredibly important. The rest aren't necessarily in order, but the next one is diet. And basically the brain hates sugar. So you really, like all the time you're taking sugar, you're poisoning your brain. So, I mean, obviously, like we need a certain amount of sugar, but essentially sugar is really bad for the brain. And the brain functions so much better. I mean, you don't need to go completely ketotic, but, like the brain functions so much better if you can try and keep your sugar intake down. The other one is sleep. And we're learning more and more about sleep at the minute. And it seems to be everyone's slightly different, but generally speaking, no less than 7, no more than 8, and keeping the sleep about sort of like the same pattern as best we can every day. Then the other one actually is hydration. That's more like you feel a lot better if you're well hydrated. And most of us are dehydrated most of the time. So like, hydration is really important. And then the last one, which is actually incredibly important, so I don't know why I put it last, is keeping your brain really active. And actually, it's not doing all these sorts of like, computer games and stuff. It's social interaction. Social interaction requires such a complex set of brain activity. So it's listening, it's processing, it's timing, it's appropriateness, it's composing what you're going to say. It's a really complex activity. So socializing is really, really important. And many people who are aware that they may be missing bits of conversations or not following the conversation, so that they're worried they might say something inappropriate, or they're worried someone might notice that, oh gosh, they've got early signs of memory loss or whatever, they actually tend to sort of like drop out of conversation. But in fact, you've really got to try not to do that. You've got to just like really keep your brain active. And the other really annoying thing I see with our patients is the person who is sort of like noticing they've got some problems with their thinking ability, starts using the other person's brain. They start using their partner's brain. And that's really bad, because then you just sort of like become a bit lazy. And that's, you then are exercising your brain even less. So keeping your brain really active is incredibly important. And, if you're bilingual, keeping both languages going, if you're you're really good at music, listening to music, playing music, dancing, all these things that just require So actually exercise to music whilst you're socializing and speaking another language. That's probably what everyone needs to do.
The socializing thing is like, that's really, now that you've explained it and broken that down, as in what it takes to socialize,
Yeah.
we just take it for granted, don't we? Like, we're socializing now, and I'm not even thinking about how many inputs and outputs are going on.
Yeah.
But there's so much there, isn't there? And I knew socializing was important and connection was important, but when you've broken it down there, that just highlights how beneficial it is, actually.
Yeah,
it really
no,
does.
it is really important. And actually, one of the things I also find very upsetting is that, if you have two people and one of them does, have cognitive problems, and the other person's there, often it'll be their partner or whatever, and the person tends to direct everything towards the partner, almost like missing out the person who's got the cognitive symptoms, and that's the very thing you shouldn't do. So you've got to keep people engaged.
And it's easy, I think, sometimes, and I say it quite a lot actually, that it comes from a place of love sometimes, doesn't it? Like protection, but actually you're not doing any favours, are you?
It's not. I mean, there's two things. Number one, the person who you have now noticed has got some cognitive symptoms, noticed these cognitive symptoms ages ago. They noticed them probably 6 months before you have even first started to notice them, sometimes a year. The second thing is, it is exactly the same as if you saw somebody with a lump on their face or a lump on their back or something, and you didn't tell them. You didn't say, do you know what? I think you need to see someone about that. Or you saw somebody was losing weight, like not deliberately, and you just sort of didn't say, do you know, I think you're losing a lot of weight. Are you okay? I think you might need to get this checked out. It's sort of like, it's weird to ignore the fact that someone's brain is obviously not working properly.
It's sort of like, I don't know if there's a bit of a fear. Like you said, we would point out a lump or I've had a cough for quite a while. My husband said that you need to get that cough checked out, But when it comes to the brain or noticing behaviour changes, it's like fear that you don't want to insult someone.
Yeah.
That you've noticed something, maybe. I don't know.
Yeah, it's really complex. In one way it's simple, in another way it's sort of complex. It's a combination of because symptoms develop very slowly, and because they're very non-specific in the early stage, and because we all have, good days and bad days, so to speak. And when you're on holiday, you sort of, someone says to you, "What's the date?" You go, "Oh God, I've got no idea." It's sort of like, we all fluctuate in this sort of zone all the time. So the first thing is, you're not quite sure. You're not sort of too sure. So it's difficult to be absolutely specific. So if I said to you, "I've got really bad pain here," you'd say, "Well, go and see the dentist." That's not difficult. So it's a little bit difficult, and you're not quite sure. The next thing, as you say, is fear. So people think, "Oh my God, if this is like Alzheimer's disease, then it's best probably just say nothing for a while because nothing can be done." That's the bit that is no longer true, in so much as that, which we'll talk about, there are treatments on the market, and there are lots of new treatments which are in clinical trial, which are like accessible purely on just clinical criteria. They're free of charge. The other thing, of course, is, as we said at the beginning, if it's something that can be corrected, you need to get it corrected as quickly as possible, because these things then become a bit insidious if not. But I think people are afraid. And I think also there's a sort of strange sort of feeling that, if you've got a pain, on the whole, people don't think, well, that's a bit weird sort of thing. Whereas if people just aren't sort of able to think properly, or they're not communicating properly or whatever, you sort of think, I don't know, it's almost like more of a judgment about that person, as opposed to, oh, well, they may just have an illness. You know what I mean? It's, again, the lump thing. You don't just think, oh, God, that's a bit weird, that person's suddenly sprouting lumps. You just think, oh my God, they must have something wrong with them. So it is also this, I don't know, disconnecting, loss of memory and things like that with, oh, this probably is actually just a condition. It's just something that needs to be treated like anything else. And I think it is demystifying Alzheimer's that's really important. Like, it's not some mystery condition. It is an abnormal accumulation of amyloid and tau protein in the brain. And we need to remove that amyloid and tau protein, or you can just say, look, it's neuroinflammation. We just need to treat the neuroinflammation. It's not some, weird, mysterious condition.
Goes back to that education again, though, doesn't it? Yeah. And talking about it openly, freely, and just making it normal.
Yes,
it's another normal disease,
Yeah, as I said, it's like cataracts. If somebody's vision is going, you don't tiptoe around it. You say, I don't know. Hear adverts for Specsavers every 2 seconds. If you can't see properly or you can't hear properly, go and get it checked.
Yeah.
You don't hide away saying, oh my God, I don't want anyone to know I can't see properly.
Yeah. It needs to be as normal as that, doesn't it?
Yeah.
So talking about the symptoms then, if somebody is concerned, what would your advice be? What would their first point of call be?
Yeah. So, obviously the sort of like in the UK, the normal thing is you see your GP, and then the GP will do a simple test and then sort of like potentially send you to the memory clinic. And obviously I would not in any way want to dissuade anyone from doing that. But I do see many people, particularly when symptoms are very mild, where it's sort of like, well, I don't know, symptoms are quite mild. And rather than moving to a diagnostic biomarker test, they say, well, look, let's see if it gets worse. So again, that's the analogy of the lump. Well, I don't know, it just looks like a lump. Let's just come back if it gets worse. So for most people who want to be really proactive, they're not usually completely satisfied with that. And one of the things that we do at Recognition Health, and I'm sure there's other people doing this as well, is actually offering the chance to get a more detailed cognitive assessment, and then also to get access to a biomarker. So we are providing at the minute a cognition test, which I think it's called Cognition Health, but it is only for people over 50, only because the biomarker test is only sort of like, calibrated and valid for that age group. But then also today, and I'll explain why today, only for people who do have some mild cognitive symptoms. They can be their own concern, or someone else has said, look, I think there's something a bit wrong here. But as long as they have to have some cognitive symptoms. And that provides an online, very accurate AI-driven cognitive assessment. So way more accurate than, like asking you what the day of the week is, sort of thing. And then it also does give you access to this blood test biomarker for the p-tau217. And it actually includes in it an MRI scan. So that's just an assessment that we provide, and it's almost all sort of like done online or close to where you live. In the US, for example, this p-tau217 test is now sort of like approved in the market and very available. So in our US clinics, for example, we're working with a company that actually provides this p-tau217 blood test in the post. So like doing a COVID test or something. And so you can actually do the p-tau217 test at home. You just put it on your arm, and then this result gets sent back in the post, and then they analyze it and they let you know if you've got high, intermediate or low p-tau217. Also in the US, you can just pop in anywhere to a sort of like, a center that just does the p-tau217 test and find out, whether you've got abnormal, intermediate or low, i.e. normal p-tau217. So it's in different countries in the world at the minute, we're all in different stages of evolution. But certainly people who are contacting us and they're saying, look, I just want a diagnosis, then we can either do it through the screening, or we can, obviously, because we can only do that either through clinical trials for free, or we can do it like on the market as a private patient. We can do the PET scans and everything else. So essentially we can take you from zero to getting a diagnosis, yes or no, very quickly.
So there's two pathways with
Yeah.
yourselves then, really, haven't they? The clinical trial route or as a private.
Yeah.
Yeah.
So the diagnostic, so to make it sort of like really straightforward, if you want to do it privately on the market, you can either do the simple screening, well, sophisticated but straightforward screening assessment, and that's all on our, on our website. You can just, you can see that really easily. Or you can make an appointment and you can have all the sort of like formal testing and a private memory appointment, etc. Separately, if you don't want to or are not in a position to be able to pay for the testing, then what you can do is, if you're clinically eligible, you can screen for a clinical trial. And in the screening for the clinical trial, you'll get all the diagnostic tests as well. Now, the only reason for doing a diagnostic assessment is to access treatment. There's no point in doing it if you can't access treatment.
Yeah.
And so the current situation in the UK, different in our US clinics, the current situation in the UK is the two new treatments that are now on the market. So they're approved by MHRA, the regulatory authority. They are Kisunla or donanemab and lecanemab or Leqembi or lecanemab, and they are monoclonal antibodies against amyloid protein. So basically, you give them through the vein as an infusion, they pop up across the blood-brain barrier into the brain, and they remove the toxic amyloid protein from the brain. Removing the toxic amyloid protein from the brain decreases that sort of like, microgliosis, decreases the progression of tau, decreases progression of symptoms. So those two drugs are available on the market, but you have to have evidence of high amyloid protein in order to qualify for those treatments. Obviously, you can't give you treatment to reduce amyloid protein if you haven't got high amyloid protein.
Yeah.
Separately from that, and so that is it, those expensive, those treatments, they are actually quite expensive, but they are available on the market. Separately from that is, if you screen for a clinical trial and you're eligible, so in other words, you've got high amyloid and you fit the cognitive profile for the trial, then you can come into a clinical trial where everybody in a clinical trial, and this is the same for all clinical trials across the world for every condition, is you will be divided, usually more people on the active medication, but you'll be divided between taking active medication and placebo. And we and the individual receiving the medication doesn't know they're on active medication or placebo. And the purpose of the trial is to see, does this active medication provide a significant difference in terms of slowing progression of disease and symptoms compared to the person on placebo. And if that is the case, then that's how medications all across the world are then assessed and get onto the market.
How long is that monitored for?
So most clinical trials for people with mild cognitive symptoms are for about 18 months.
Okay.
And then at the end of that 18-month period, in most studies, the people who have been on the placebo then get the active medication. So what normally tends to happen is everyone's either on active medication or placebo for the first 18 months. And then after that, everyone goes on the active medication. So for example, the two new medications that are on the market today, so donanemab, lecanemab, also known as Kisunla and Leqembi, we have done all the clinical trials for those medications as well. So most of the people who were on donanemab and lecanemab in the final phase of the clinical trial all came into the clinical trial so around the beginning of lockdown, so around 2019 and 2020. And so they've all, in fact, nearly everyone in the UK who has been treated and were on the sort of trial that, was the successful, were the successful ones, they were all treated in the clinical trial. And of course, now they're very happy because they were the sort of like the two medications that were successful from those trials and which are on the market. But, the first person to sort of like these slow down progression disease and all the new trials coming through, there's no point in creating a drug that gets on the market that's not as good as the ones that are on the market today.
Yeah.
And so, you could extrapolate the first person to be cured of Alzheimer's disease will be on a clinical trial. I mean, that is sort of like how clinical trials work. But the most important thing today is that you get a biomarker diagnosis as quickly as possible, and you get access to a new generation disease-modifying treatment, either on the market, but they are expensive, or through clinical trials. And the only difference between clinical trials is you don't know at first if you'll be on active medication or placebo. And obviously you don't know if that's a medication that's going to be the one that works. I mean, we do lots of clinical trials that don't necessarily result in the drug getting on the market. But you got more chance of slowing down progression of your disease if you're in a trial than if you're not. And obviously we know the drugs that have come on the market have been successful in clinical trial, and they are slowing progression of disease and symptoms. So I saw somebody literally just this morning, about half an hour ago, who was on Kisunla, and we just did the PET scan yesterday and got the result this morning, and all her amyloid plaque has been removed. So, this is really happening, and it's really happening right now. Now, obviously, I do understand that many of the people listening will be thinking, well, what about in the NHS? So the answer is today in the NHS, because for a drug to be available through the NHS, it has to be approved by NICE, the National Institute of Clinical Excellence. So NICE has to look at the whole of the NHS budget, has to look for, all sorts of different things that are financial as well as clinical. So today, these two drugs, Kisunla, Leqembi, are not available via the NHS. But that may change sort of like at any minute. New medications will be coming out as well, which may then be available by the NHS. But the most important thing is that if your symptoms are mild now, you may not still have mild symptoms by the time these drugs come on, are available through the NHS. So that's why I say, look, either get in a clinical trial or get the drug on the market. And the whole thing about this, the way to change the whole paradigm is you need to stay mild, because we know the other drugs that are all coming through in the market, they too are most effective when symptoms are mild. And it's all about staying mild, because then you get on this drug, this drug, this drug. And that's what will change as an individual. That's what will change your future. And that's what will change the future for all of us. And the drugs on the market at the minute, and most of the clinical trials, you are only eligible for these treatments when your symptoms are relatively mild. So once the symptoms have progressed beyond that point, and obviously we know how to determine where they are, then it's sort of like too late for what we call these disease-modifying treatments. So it's to be honest, it's a bit like treating anything. It's like treating cancer. A medication that will work when you're on phase 1-2 of cancer won't necessarily work once that cancer is metastasized. So the key thing is, once the sort of like town's gone crazy, then just removing the amyloid protein, it's like it's too late. So that's why it's, it is the same as cancer. It's, you've got to get diagnosis and treatment early. And the reason the biomarkers are so important is because when symptoms are mild, which is when these new treatments are effective, you can only confirm the diagnosis by a biomarker. You can't confirm it by talking to somebody or doing 100 million billion cognitive assessments.
What's the timeline for somebody coming to you as a private patient to getting that diagnosis after assessment and testing?
So we have two things. We have many people come to us, they've already had lots of, they've already had all the assessments done by another physician. So I spoke to somebody yesterday who'd had all the assessments done. It's actually someone who's in Ireland, because we have people coming from all over Europe. And they'd had all the assessments done. I spoke to them yesterday, and they will start treatment either later this week or early next week. So then for somebody who's had nothing done at all, they're just a bit worried, about 2 to 3 weeks. And if they're going to get into a clinical trial, that takes a bit longer, just because you have to go through so many, there's a lot more hoops, so to speak.
Yeah.
But usually the sort of like screening period for a clinical trial is between sort of like, it's usually around 60 days. But often in the clinical trials, you have additional tests done as well, because they're collecting a lot of data to try and understand as much as they possibly can about an individual's disease and also their response to treatment.
And what's the costs involved?
So I don't want to sort of like, it's all like, anyone who's interested can obviously like, apply to
Yeah.
us straight away, but I sort of just don't want to sort of like come out with the
Yeah.
cost, you know what I
Yeah.
mean? But it's all available if anyone wants to look and ask us, we provide all of that information. For the clinical trial, there's no cost. In fact, like your travel expenses, I mean, up to a certain sort of cap,
Yeah.
everything are paid. So it's sort of like, it's not exactly we pay you, but it's almost,
Yeah. Yeah.
it's
Yeah.
free. I mean,
Yeah.
nothing's free. I mean, these big clinical trials cost over $1 billion or pounds to deliver, which is why drugs are expensive when they come on the market, because
Yeah.
research and development is so expensive. But to the individual, there's no cost if you're on a clinical trial.
And what's the medication at the moment? What's that on the market for, roughly? Do you know?
So the two that are on the
Yeah.
market at the minute, they are what we call amyloid targeted treatments. So they're monoclonal antibodies against amyloid protein. So essentially, it's very simple. I mean, the medications are given in the vein. They whiz up. The clever bit is they get across what's called the blood-brain barrier.
Yeah.
They get into the brain. They attach to this abnormal toxic amyloid protein, and they remove that toxic amyloid protein from the brain. I mean, it's terribly complex in terms of like, the very, very clever people who develop these treatments. But that's it.
Yeah.
I mean, it's the same as saying, how do we treat, I don't know, like diabetes. I mean, there are obviously lots of different types of treatments, but essentially it's bringing your blood sugar back into the normal range. So this is bringing your amyloid protein back into the normal range.
But what's the financial cost of that medication?
So that was what I was saying. I wasn't going to say exactly what the cost
Yeah.
of that is.
Yeah. Yeah.
But we can provide that to, like anyone who's interested, we can send all of the information and everything.
Yeah.
Yeah, I mean, and there's two medications. There's the Leqembi, which is given every 2 weeks, and the Kisunla, which is given every 4 weeks. And they do have slightly different costs and everything as well.
Okay. But effectively both doing the same.
They're both doing more or less the same thing.
Yeah.
There are slight differences between the two. But effectively, yes, they're more similar than they are different. And they are essentially both removing the amyloid protein. I mean, I can go into it in sort of like more detail, but do you know what I mean? I mean, essentially they're both removing the amyloid protein. And you want to remove the amyloid protein per se, because that's sitting on the brain cells and killing off your brain cells, but also because all the time the amyloid's high, it's driving microgliosis, which is driving the tau protein, which is inside the brain cells, to spread through the brain cells. And that's what correlates with the progression of symptoms. So that the amyloid is inside the brain, but outside the brain cells. The tau protein is inside the brain, inside the brain cells.
Very confusing unless you've got a scientific brain, but you've explained it very well and helped me understand it a little bit more as well. Finally, before we finish, if I could ask you to give the listeners one piece of advice or guidance, what would that be?
Can I give two?
Go on then.
All right.
Of course you can.
Okay. Yeah. Number one is loss of memory and other aspects of your thinking ability as we grow older is not normal. First bit.
Okay.
Second bit, if you are experiencing problems with your thinking ability and particularly short-term memory, then I really would advise you to take that very seriously and to seek, through whatever route, a diagnosis, an accurate diagnosis, not be told, oh, no, it looks fine, I think you're all right. Seek an accurate diagnosis because you know if there's something wrong. And if possible, seek early access to what we call a disease-modifying treatment, these new treatments, either on the market as a private patient or through a clinical trial completely free of charge. And the clinical trials are available like through us, through other, sort of like independent sector centres, and through the NHS. The clinical trials are everywhere. And whatever you do, don't do nothing, because it could just be something that's reversible. And don't sit there sort of, thinking, oh my goodness, I need to hide this away. It's nothing to be embarrassed about. You need to get it treated.
Yeah, the earlier the better, for sure.
Yeah, and the final bit is that the medications on the market that people will be aware of, donepezil, rivastigmine, galantamine, memantine, they are what we call symptomatic treatments. So the analogy would be, if you're treating cancer, the new medications are like the chemotherapy.
Mm-hmm.
And the current medications, the symptomatic donepezil, rivastigmine, galantamine, memantine, that's like taking a painkiller for cancer. They're just treating symptoms.
Okay.
So the new medications stop the brain cells from dying or slow it down. The symptomatic medications just help the dying brain cells work a bit more effectively and efficiently. And I do think it's really important people understand that.
Yeah, a good piece of advice.
And be optimistic, because like this is a changing, cautious optimism is entirely appropriate.
Yeah, and that's the importance of the early diagnosis and the medication, is so that you can live longer and better, rather than sitting and hiding and waiting and not doing anything.
I've done a TED talk which is called Today Our Brains Are Dying Before Our Bodies, which is about CTE but also about Alzheimer's. Don't let your brain die before your body. Not good.
I will put the link for the TED Talk on the show notes as well.
It's only 6 minutes.
If people want to find out more about Recognition Health, how do they get in touch?
So just to be honest, the easiest thing is just to go on our website, which I think it's like www.recognitionhealth.com. There's so much on there, including all the contact numbers. So, we have a team of people that literally answer the phone, because they answer for US and UK. So they answer pretty much 24/7, and they really know a lot about everything. So I think they're answering the phone from about, 8 in the morning UK time to about 2 in the morning UK time.
Wow. Okay.
So just go on the website and then just contact us.
Yeah. Any questions, pick up the phone and ask. Yeah.
Yeah. And pick up the phone and ask. I mean, our phone number is 020 3355 3536.
Perfect. And we'll put the website on the show notes as well. Thank you so much for joining me today. We've learned a lot there, and the importance of early diagnosis. Any doubts, go and get checked out. Fantastic. Thank you so much. Thank you.
Thanks very much. Bye-bye. Bye.
Perfect.